So femoral triangle anatomy is complete. You have read femoral triangle. Okay, so today we will discuss the applied aspects of the femoral triangle. Okay, different clinical aspects. Happy New Year to you all. Okay, next. So these three topics mainly we will discuss: femoral hernia, psoas abscess, and fracture neck of the femur. Okay. Next. So femoral hernia occurs through the femoral canal. Okay. So to know the femoral canal, you have to first know the femoral sheath. Femoral sheath comes in your long question. Okay, and also this femoral hernia comes as a part of long question, and it can also come as a short note, femoral hernia. Okay, femoral hernia, inguinal hernia, both are very important. So we will first discuss the femoral sheath. Femoral sheath, this is the location of the femoral triangle. Here lies the femoral sheath. Femoral sheath, also known as crural sheath, it is a fascial sleeve enclosing the upper part of the femoral vessels in the femoral triangle. What is the shape of the femoral sheath? It is funnel shaped and broad end is directed upward. Okay. How it is formed? Femoral sheath. Femoral sheath is derived from downward prolongation of two fascias from abdomen to the thigh. Okay. Two fascia is elongated downward to form the sheath. Sheath has a anterior wall and one posterior wall. Anterior wall of sheath is the extension of the fossa transversalis of the anterior abdominal wall, and posterior wall of sheath is formed by the fossa iliaca that covers the iliacus muscle. Okay, so that's how the femoral sheath is formed. Next, see here, these are the anterior abdominal muscles. Okay, from anterior to posterior, these are external oblique, internal oblique, transversus abdominis. After you get the fossa transversalis. Okay, fossa transversalis is extended downward and forming the anterior wall of the femoral sheath. Here one femoral artery has been shown, which is a content of the sheath, and this posterior layer of the femoral sheath is formed by the fossa iliaca. See, this is iliac bone. In the iliac fossa, this iliacus muscle is attached, and this muscle is covered by this deep fossa sheath that is known as fossa iliaca, which is forming the posterior layer of the femoral sheath. Okay, so this is formation of the femoral sheath. Next, see, we have learned this is funnel shaped. So upper part, this is the broad end, and this is the narrow end, and it has three compartments. Lateral compartment is containing the femoral artery along with the femoral branch of genitofemoral nerve. Intermediate compartment is containing femoral vein, and medialmost compartment is known as the femoral canal, and through this femoral canal femoral hernia is occurring. Okay. And this upper end of this femoral canal is known as the femoral ring. And what is the content of this femoral canal? Content is deep inguinal lymph nodes or Cloquet's lymph node, and here lies over the anterior wall there is a opening. This is known as saphenous opening, through which enters the great saphenous vein and drains into the femoral vein. Great saphenous vein is a tributary of the femoral vein. Okay, so this is the anatomy of femoral sheath. Next, so termination of femoral sheath, this is a cross section through the femoral sheath. Okay, lateralmost compartment containing the artery and the femoral branch of genitofemoral nerve. This is femoral vein, and here is the lymph node in the femoral canal. So inferiorly the femoral sheath blends with the tunica adventitia of the femoral vessels and disappears, and hence the lower margin of femoral sheath is ill defined. What are the compartments? Femoral sheath is divided into 3 compartments by medial and lateral septa, which is directed antero-posteriorly as divided into 3 compartments. Lateral compartment contains the femoral artery and femoral branch of genitofemoral nerve. Intermediate compartment contains the femoral vein, and medial compartment, also known as femoral canal, contains the lymph node of Ploquet or Rosenmuller. Okay, see, content is important. And the clinical aspect is femoral hernia. Femoral hernia occurs through this femoral canal. Next. So, this is the summarization of femoral sheath. It is a funnel shaped fascial sleeve. How it is formed? Anterior layer formed by extension of fossa transversalis, posterior layer by extension of fossa iliaca. Termination, inferiorly it merges with tunica adventitia of the femoral vessels. And compartments with contents divided by 2 septa into 3 compartments. Lateral compartment contains the femoral artery and femoral branch of genitofemoral nerve. Intermediate compartment contains femoral vein. Medial compartment, also known as femoral canal, contains lymph node of Ploquet and Rosenmuller. Okay, and femoral hernia occurs through this femoral canal. Next, silence. Okay, so now we will discuss femoral canal in details. So, femoral canal is the medial compartment of the femoral sheath, and femoral canal is the medial compartment of the femoral sheath, and laterally it is separated from the intermediate compartment of femoral sheath with the femoral vein by the medial septum. What is the shape of the femoral canal? It is conical in shape, and its wide base is directed superiorly and it is narrow inferiorly. What is the dimension? Length is about 1.5 centimeter, width is about 1.5 centimeter superiorly at the base. Base is also known as femoral ring. These terms are important, very frequently asked in your viva. Where the femoral canal is located, what is femoral ring, content of the femoral canal, all those are asked in your viva or OSPE question. The base of the femoral canal is called femoral ring. What is the boundary of femoral ring? Anteriorly it is bounded by the inguinal ligament, posteriorly by the pectineus muscle, medially by the lacunal ligament, laterally by the medial septum separating the femoral canal and intermediate compartment of femoral sheath. Okay. So, this is the boundaries of the femoral ring. Next, femoral septum. It is a condensation of extraperitoneal connective tissue that closes the femoral ring. Okay, that is known as femoral septum. Femoral fossa. What is femoral fossa? It is a depression of the parietal peritoneum that overlies the femoral ring. That is known as femoral fossa. What is the content of the femoral canal? Lymph node of Ploquet or Rosenmuller and loose connective tissue. These two are the content of the femoral canal. What is the clinical integration? Femoral hernia. What is femoral hernia? It is protrusion of abdominal content into the femoral canal. That is known as femoral hernia. This is the definition. Next. Okay, so abdominal content will protrude first through this femoral ring, then it will enter through this femoral canal, then it comes out through this saphenous opening and lies over the thigh. Okay. Next, these 3 compartments you have seen, this is part of the femoral canal. Next, okay, so femoral canal, its summarization, it is the medial compartment of femoral sheath. Shape is conical, base is directed upward. Dimension, length is about 1.5 centimeter, width of the base is 1.5 centimeter. Base, base is known as femoral ring. What are the boundaries of femoral ring? Anterior boundary by inguinal ligament, posterior boundary by pectineus muscle, medial boundary by lacunal ligament, and lateral boundary by the femoral vein. Others, it is closed by femoral septum and related to the femoral fossa superiorly, which is a site of femoral hernia. Okay. Next, so femoral hernia, this is the definition, it is herniation of the content of the abdomen through the femoral canal. Femoral canal is the medial compartment of femoral sheath, and this hernia is more common in females due to wider femoral canal and smaller femoral vessels. Okay. So, it will get more space for herniation, abdominal content will get more space as the vessels are smaller in diameter, and also in female pelvis is wider. Okay. And femoral hernia is, this is very frequently given explain why question. Why femoral hernia is more common in females? Okay, very important explain why question. Femoral hernia is common in adults than children and is never congenital. Okay, inguinal hernia can be congenital or acquired. Okay, but femoral hernia is never congenital, always acquired. What is the composition of the hernia? Hernia consists of coverings and loops of intestine, peritoneum and blood vessels. Okay, these can be involved in hernia. Hernia has a neck and a sac. Neck is the narrow part and sac is the bulging part. What is the course of the hernia? First, the femoral hernia passes downward through the femoral canal. Okay, then forward through the saphenous opening and then upward along the superficial epigastric vessels. So, first it will descend downward, then forward through the saphenous opening, okay, and then upward. Hence, for reduction of the femoral hernia, you have to reverse the course, reverse course should be followed. So, you have to push the content first downward, then push through the saphenous opening backward and then push it to upward, okay, so that it can again enter into the abdominal cavity. Next, what is the classification of femoral hernia? Reducible femoral hernia, irreducible femoral hernia, obstructed and strangulated. These are the 4 types. So, reducible, when we will say it reducible, when the content of hernia can be pushed back into the abdominal cavity, that is reducible hernia. Then irreducible hernia, when a hernia cannot be pushed back due to adhesion between the wall of hernia sac and its content. Okay. So, it cannot be pushed back into the abdominal cavity. Next, we go to obstructed femoral hernia, when a part of intestine in the hernial sac gets obstructed due to twisting or constriction. Okay. Next, we go to strangulated, when there is loss of blood supply to the herniated intestinal part and it requires surgical correction to widen the femoral ring and reduce the hernia, because in strangulated hernia there will be pain and also there will be high chance of necrosis and perforation, okay, because the blood supply is lost, it will not get oxygen or nutrient the strangulated part. So, that is why it is emergency surgical correction is needed for reduction of the hernia. And in obstructed hernia, there is loss of blood supply has not occurred, but there is twisting of the hernial sac, and this will ultimately lead to this strangulated femoral hernia. So, reduction of the hernia in their normal anatomical position, it can be done manually or surgically based on the type of this hernia. Okay. Next, see the hernial coverings and their contents. See, this is the hernial content. See, this is peritoneum. After that, peritoneum, this is fossa transversalis, okay, and these are the abdominal muscles. skin, subcutaneous fatty tissue. After that you get the muscles, 3 flat muscles of abdomen, external oblique, internal oblique, transversus abdominis, after that fossa transversalis, then and then there is the peritoneum. Okay. So these are the contents, that means intestine or blood vessels like this. These are entering through the femoral canal and it is pulling along with it the peritoneum, fossa transversalis, and this is the deep fossa. Okay, and this is skin. So there is a bulging in the skin near the thigh region, medial aspect of the thigh region, and these are the covering from outside inward: skin, superficial fascia, then deep fossa, cribriform fossa. Cribriform fossa is the covering of the saphenous opening, and this is the content, this was content of the femoral canal, lymph node of cloacoid. Then there will be the covering of the fossa transversalis, which was forming the femoral sheath, and then there will be covering of the peritoneum, and this is the content containing the herniated loop of intestine, also may contain the blood vessels. Okay, so this schematic diagram is showing different contents and coverings of the femoral hernia. You practice a schematic diagram like this for femoral hernia. Next, features of okay. So we have completed femoral hernia. Okay, for treatment you have to do manual reduction. After that, surgical correction you have to do for the femoral hernia. And next we go to the fracture neck of the femur. Okay, very frequently occurs in old age, fracture neck of femur. So large amount of force is needed for fracture of femur, and the neck of the femur is the weakest part of the bone and most frequently fractured. These fractures are more common in individuals aged 60 years and above, especially in females due to osteoporosis. Okay. Due to hormonal changes, there is osteoporosis is more common in females after menopause. What are the types of fracture? This is very frequently given short note, fracture neck femur. Okay, important short note, fracture neck femur. So fractures of the neck of femur are grouped as follows: subcapital fracture, transcervical, intertrochanteric, peritrochanteric. Okay. So subcapital means, capital means head, capitamen means head, subcapital means just below the head. So subcapital, here is the subcapital fracture occurs. It occurs near the head. Next, transcervical. So this is head, this is neck, these are the trochanters, greater and lesser trochanters. So if the fracture occurs here in the neck, then it is known as transcervical fracture. Then intertrochanteric fracture extending between the trochanters. See, this is the intertrochanteric fracture. Next, peritrochanteric fracture. It just distal to the trochanter here. Pretrochanteric or peritrochanteric you can say. Next. Okay, now we will see the radiographic feature of the fracture neck of femur. Shenton's line on the radiograph. See, this red colored one, this one is known as Shenton's line. It is a continuous arc line drawn from lower border of neck of femur and the upper border of obturator foramen. This is hip bone. This foramen is known as obturator foramen. Okay. So this lower border of neck of femur and upper border of this obturator foramen, this forms a continuous arc, okay, in normal person. So this arc is known as Shenton's line. In case of fracture neck of femur, here fracture occurs. After fractures, the two ends will displace. That's why Shenton's line will not be maintained. Okay. In case of fracture neck femur, Shenton's line cannot be maintained. So what is Shenton's line? Continuous arc line drawn from lower border of neck of femur and the upper border of obturator foramen. And discontinuity of the line indicates the fracture of the neck of the femur of or hip dislocation. Okay. In hip dislocation also, head will not located in this acetabular cavity, it is displaced forward or backward. So, there also sentence line will be destroyed. Next is Shoemaker's line. It is a line projected from the tip of the greater trochanter here. This one is Shoemaker's line projected from the tip of the greater trochanter to the anterior superior iliac spine here, anterior superior iliac spine, and it passes above and through the umbilicus. Okay, if it is extended upward, it passes above or through the umbilicus. In case of fractured neck of femur with elevation of greater trochanter, the Shoemaker's line passes below the umbilicus. Okay, so in case of fractured neck, it will be pulled upward. So this line will extend, it will be more horizontal and it will pass below the umbilicus. Generally it is passing through umbilicus or above the umbilicus, but in case of fracture neck it will pass below the umbilicus. That is the difference. In case of fracture neck, what is the treatment? It generally occurs in old age. Okay, so you have to, there is less chance of recovery from the fracture. So you have to do hip replacement surgery. So hip replacement or arthroplasty is a surgery for replacement of worn out or osteoarthritis or damaged hip joint with an artificial joint or prosthesis. You have to put a prosthesis like this. Okay. This is of generally metal, made up of metal. There is complete arthroplasty or partial arthroplasty. If there is need, you have to change both acetabular cup and also the head. You have to change both. And if there is no need in partial arthroplasty, generally this acetabular cup is not changed. This femoral head is placed over the upper end of the femur. So, generally done in osteoarthritis or damaged hip joint with an artificial joint. Prosthesis has been put, it may be partial or complete hip replacement surgery. Okay. Next, or you can place a dynamic hip screw fixation. Okay. If destruction is not much, it can be done, dynamic hip screw fixation. It is an orthopedic implant designed for fixation of fracture of the neck of the femur. Okay. So this is a plate and these are the screws. Okay. The screws are fitted with the femur and this large screw is entering from this below the trochanter up to the head of the femur through this neck. Next we go to the iliopsoas abscess or psoas abscess. Iliopsoas muscle is lying together, okay, and they are together covered by a deep fascial covering, okay. So in case of abscess or pus formation, they are lying contained within this iliopsoas fascia, that is known as iliopsoas abscess. So psoas or iliopsoas abscess is collection of pus in the iliopsoas muscle compartment. The incidence is rare, but the frequency of its diagnosis has increased with the use of computed tomography scanning, CT scan, prior to which most cases were diagnosed at post-mortem. Okay, it was not diagnosed previously. Next. Okay, see, these are the psoas muscle. What is the location of psoas muscle? Psoas muscle is fusiform muscle. You will see the psoas muscle in posterior abdominal dissection class. Okay, so it is a fusiform muscle cover anterolateral surface of the lumbar vertebral bodies, arising from lumbar vertebral bodies. What is the origin? Lateral surface, intervertebral disc and transverse process of T12 to L5 vertebra. What is the course? After origin passes inferiorly along the pelvic brim and iliacus muscle beneath the inguinal ligament towards the anterior thigh. Okay. Psoas major joins with iliacus. Iliacus was arising from the iliac fossa of the hip bone, and together they are covered by a common sheath. Insertion into the lesser trochanter of the femur. Both of the muscle are inserted over here near the lesser trochanter of the femur. What is the innervation? L1 to L3 spinal nerves and primary flexor of the hip joint. This psoas major is primary flexor of the hip joint. Okay, and lumbosacral plexus is lying within the substance of this psoas major muscle. Okay, lumbosacral plexus. Next, important nerves of abdomen are coming out from the lumbar plexus. Okay, from the lateral border, ilioinguinal, iliohypogastric, all these nerves are coming out laterally. Femoral nerve, and from the medial aspect of this psoas major coming out obturator nerve. All these are branches of the lumbar plexus, and this plexus is formed within the substance of this psoas major muscle. That's why this muscle is important. So, the iliopsoas compartment is an extraperitoneal compartment because it is anteriorly covered by the peritoneum. Extraperitoneal means outside, it lies outside the peritoneum, contains the iliacus and the iliopsoas muscle. The iliopsoas muscle is rich blood supply from the lumbar, iliolumbar, obturator, external iliac and common femoral arteries, and predisposes the iliopsoas to hematogenous spread of infection. Infection can come from these arteries. All these arteries are supplying the iliopsoas muscle. See here, this is iliacus, this is psoas major. These two are joining to form a common tendon, inserting over this lesser trochanter of the femur. Next, okay, what is the relation to the hip joint? This tendon is separated from the hip capsule by iliopsoas bursa, which is a communication joint space in up to 15% of cases, and which may facilitate spread of infection between these two sites. Infection readily spreads to the muscle from contiguous vertebra. Okay, this psoas major was originating from the vertebral bodies. In case of vertebral infection, like in tuberculosis of vertebra or in other infectious disease of the vertebra, it may spread to this iliopsoas muscle. Psoas major runs under the inguinal ligament. Okay, inguinal ligament is lying over here, joining this anterior superior iliac spine and this pubic tubercle. Okay, so iliopsoas lies posterior to this inguinal ligament. The psoas major runs under the inguinal ligament, attaches to the lesser trochanter of the femur. A psoas abscess often presents as a mass below the inguinal ligament. Okay. Next, what is the pathogenesis? How the psoas abscess is formed? According to the pathogenesis, it is divided into, iliopsoas abscess is divided into primary abscess and secondary abscess. Primary abscess is result of hematogenous or lymphatic seeding from a distant site, which may be a occult site. Okay. What are the risk factor? Diabetes, okay, and HIV infection, renal failure, immunosuppression. These are the main causes. And intravenous in drug addicts, it can also spread through the blood. Trauma and hematoma formation can predispose to development of psoas abscess. Okay, in road traffic accident, there may be deep trauma and it may lead to hematoma formation because they are rich in blood supply. So, there may be hematoma formation within the muscle, and later the hematoma liquefy and gets infected to form the psoas abscess. And it occurs mostly in children and young adults, more common in tropical and developing countries, and in Asia and Africa 99% are primary infection. In Europe and North America 17 to 61% are primary infection. Next, secondary abscess. It occurs as a result of direct spread of infection to the psoas major from adjacent structure. Okay, that is contiguous extension. That means related adjacent structures are infected. That is the primary site of infection. From here, it is spreading to the psoas major muscle. Okay, they are not spreading through lymphatic or hematogenous spread. It may be uncertain whether involvement of a contiguous structure is a cause or a consequence of the psoas muscle abscess. What are the risk factors for secondary abscess? Include trauma and instrumentation in the inguinal region, lumbar spine or hip region. Okay. Adjacent structures are the vertebral bodies and discs, the hip joint, the gastrointestinal tract, genitourinary tract and vascular structures. In case of infection of all these structures, it can spread to the, it can lead to iliopsoas abscess. Okay. Next, see here, this is a section through the lower part of the pelvis. Here you can see these are sections of the kidney. Around the kidney there is perinephric fat, and this is psoas major muscle. This is vertebral body. This is the spinal canal containing the spinal cord covered by the meninges. Here is the psoas major muscle, and these are the transverse processes. This is spinous process of vertebra. These are the back muscles. Okay, latissimus dorsi, quadratus lumborum. Here is the sacrospinalis and other back muscles. And these are the flat muscles of the abdomen, external oblique, internal oblique, transversus abdominis. And covering this perinephric fat, here is the renal fossa, fossa of Gerota. Okay. And posterior to it, here lies the paranephric fat. Okay, you will see during the viscera of the kidney. So this is the location of psoas major. So in case of abscess, here you will see the abscess in your CT scan plates. Next, so spread of infection occur from gastrointestinal disease is the most common source, and renal disease second most common source. An extension from psoas major into the iliacus muscle is a common sickle. Okay. In tuberculous infection from Pott's spine, it can spread from the vertebra, and in pyogenic infection it can spread. Next, pyogenic means pus forming. What are the secondary causes of psoas abscess? These are the main causes. It is dividing into these divisions. Gastrointestinal cases like Crohn's disease, diverticulitis, appendicitis, colorectal cancer can spread to iliopsoas abscess. Then there is genitourinary causes, urinary tract infection, malignancy, ESWL. Okay, this is also a infection of the kidney. And musculoskeletal spondylitis or spondylolisthesis and vertebral osteomyelitis, TV spine, septic arthritis, infectious colitis, all these are musculoskeletal causes for psoas abscess. Next, vascular causes, infected abdominal aorta and femoral vessel catheterization. Okay, these are the common causes. Miscellaneous causes are endocarditis, intrauterine contraceptive device, suppurative lymphadenitis, epidural anesthesia. These are causes. IUD, intrauterine contraceptive device, sometimes is pierced through the uterine wall. Okay, it generally it is copper T. This is a common example is copper T. It is inserted postpartum, and during the postpartum session, the wall of the uterus is very thin and it is very weak. So due to pushing it inward, it can pierce through the uterine wall and it can hurt the posterior abdominal wall, hit the psoas major muscle, can lead to abscess. So, all these are causes of secondary abscess in the psoas major. Next, okay, so what are the microorganisms involved in psoas abscess? It varies with geography and pathogenesis of the infection. Primary psoas abscess, mostly single organism can cause primary abscess. Most common bacterial cause is Staphylococcus aureus, including the methicillin resistant Staph aureus (MRSA), followed by Streptococci and E. coli. Mycobacterium tuberculosis or TB is also a common cause as a complication of Brucella spondylodiscitis in endemic areas, not common in all the areas. And secondary psoas abscess may be non-monomicrobial or polymicrobial. Enteric organisms, particularly in setting of abscess with gastrointestinal tract origin, and anaerobes too, they are involved. Klebsiella pneumoniae, especially in patients with diabetes, it causes psoas abscess, and others involved are the Streptococcus pneumoniae, Streptobacillus moniformis, Staphylococcus lugdunensis, and Actinomyces israeli, and disseminated nocardiosis. All these are causes of psoas abscess. And non-typhus salmonella, candida albicans, these are rare infection. These are it occurs in immunocompromised patient, HIV infected or like this. Okay. So this is important for your viva. It will read in your microbiology also. Klebsiella pneumoniae, more common in diabetes. A primary cause is mostly Staph aureus, Staphylococcus aureus. Okay. So these are the causes of microorganisms involved in psoas abscess. Okay, so we have completed our 3 topics. So what will be the treatment? There will be, you have to diagnose the organism and you have to give appropriate antibiotic for that, and if we need, you have to drain the abscess. Okay, so that is the treatment protocol, and conservative treatment is also done. Okay, so any queries regarding these 3 topics? So you prepare femoral sheath. Silence everyone. So you prepare the femoral sheath as your long question, okay? And femoral canal, its boundaries, and femoral hernia prepare as a short note. Neck fracture neck femur is also important short note. You practice a schematic diagram. Also for femoral sheath you practice schematic diagram, practice diagram for femoral hernia, okay. And the psoas abscess is also given as a short note, but not very frequently it comes. Previous 2 topics are very important, fracture neck femur, femoral hernia, femoral sheath very frequently given long question. Okay, understood? Short note, femoral canal comes as a short note. Femoral sheath means you have to write down all the 3 compartments, their contents, extension of how it is formed, where it ends, all these you have to write down if femoral sheath comes. Okay, understood? Any queries regarding today's topic? You have seen in the dissection portion, femoral triangle, you have seen, na? Okay. Okay, any other queries?